I take two. Welcome everybody to the United States Brain Injury Alliance webinar on measuring resource facilitation outcomes and the impact on advocacy. My name is Jeffrey Lauer and I am serving as the chair of the USBIA. I'll be the moderator today, and I'm pleased to introduce Dr. Lance Trexler, who is here with us today from the Rehabilitation Hospital of Indiana, Indiana University School of Medicine. Dr. Trexler serves as Executive Director of Research and Development for the Department of Rehabilitation Neuropsychology at the Rehab Hospital of Indiana. He has a long and lustrous pedigree, publishing more than 30 book chapters and peer-reviewed articles, and he's given literally hundreds of reviewed and invited presentations at conferences throughout North America. He's active in the ACRM, particularly focusing on the brain injury interdisciplinary special interest groups, and he's been a champion at translating evidence-based recommendations into practice by ACRM, which many professionals rely on to know how and when to try to navigate rehab after brain injury. He also chairs the Cognitive Rehab Committee, which has provided oversight for national and international workshops, and his current research and program developments are focused on resource facilitation to improve return to work and return to school and long-term outcomes for people with brain injuries. So Lance, thank you so much for coming today, and you've got I think some slides that you can put up, and we'll let you take it from here.
Well, thank you, Jeffrey. Pleasure as always. Thank you. Can you see my screen, my slides? It's my first question, I guess. No?
Yes, we can see your slides.
Yes, I can see your
great.
slides.
All
Thank
right.
you. Sorry.
All right, great. Thanks very much. So yeah, I'm going to talk about this program of research and clinical development and policy development that we've been engaged in now for, I guess, about 11 years, specifically around resource facilitation. Have a great deal of respect for all the work that's going on out there in resource facilitation. And we've kind of crafted an Indiana model or approach to this that I'll review now over this talk and give you some ideas about what some of the outcomes have been and talk about how we've rolled that out. So thank you very much for your interest. And what we'll do here is, let's see, do you guys, I want to make sure, do you see my next slide now or maybe not? No, you don't. You see still my title slide. There we go. Okay. So we started off by looking at a vocational outcome for resource facilitation. And we did this in context of a randomized controlled trial. Actually, my wife got me into resource facilitation. She was working on a HRSA grant and got involved in resource facilitation. And we began talking about the model and its obvious utility. But we also began talking about the fact that there was no evidence. It sounded like a really good idea. It probably was a really good idea. But the question I had as a research nerd was well, okay, where's the data? And so we decided to start. We had a little bit of money left from a grant. And we thought, well, why don't we just do a small randomized controlled trial to look at vocational outcomes associated with resource facilitation. But first, I also wanted to know, okay, what is the return to work rate, irrespective of whether you have resource facilitation or not. And I think probably one of the better studies came out in 2015. Looked at 3,100 subjects in the TBI model systems database, and then they weighted these data based on population estimates. So that ultimately results in this enormous sample size of about 75,000. And of those, 72,000 were not retired. So that was the applicable sample. But it was also then we looked at, it was important to look at those who were alive. And so 64,000 of those people were still alive, resulting in the finding that about 40%, 39.6% of people following probably mostly moderate to severe traumatic brain injury, that is people that went through inpatient rehabilitation, were competitively employed at 39.6%. And unemployed was 60.4%, which is of course pretty striking. Interestingly, though, employment in their model include paid legal or illegal work with or without accommodation. So what I said earlier about competitive may be not necessarily true. Paid legal or illegal work with or without accommodations. And of those, 65% were full-time. However, when we started working with Indiana Vocational Rehabilitation in 2009, their communication to us was that they were getting about 18% successfully back to work at that time. And there's probably a really good reason for that, in that if you've had trouble returning to work, on your own, and you're so you're going to ultimately reach out, to vocational rehabilitation, it could be the case that they're getting the most difficult cases to get reemployed. Don't know that for sure, but that was what we were told was their base rate. Let me just give you a definition of how we define resource facilitation. First of all, it's designed to be proactive, and we did that. We structured it that way because, of course, we know that our folks have some difficulties with initiation, with organization. Their lives, the families' lives are incredibly busy, and so we wanted to be proactive and initiate interaction with them. Not, we didn't want to be in a position of responding to. We wanted to reach out to them at a scheduled frequency. We wanted the scope to be broad, that is, to focus on instrumental as well as brain injury specific services, and also community and vocational supports and services. So it's kind of the whatever it takes model. I believe Barry Willer in New York was the fellow who coined that term. But we do everything from help people find housing to get reimbursement for services, to find a good neuropsychologist or PM&R physician. The other thing that we wanted to emphasize was brain injury education. So many of our people, and I suspect this is true for you also, really don't know what happened to them in terms of the specifics of their injury and how that has affected them, and also that education was typically not provided to families, and so the misunderstanding about their condition was usually much more common than really having a good handle on that. So we wanted education to be a huge issue, in addition to, of course, promoting awareness. And then the third dimension of resource facilitation in our model is then collaboration and integration. So helping the mental health provider understand that person's brain injury and how it affects their functioning, and what might be done to help them provide mental health services in a way that accommodates the effects of that injury. We also wanted to make sure that the multiple providers are connected, and someone's got the big picture of all the services that this person might be receiving. So there's actually two levels of resource facilitation in our model. And we did that because when we reviewed the literature on predictors of return to work, it was clear that the barriers to successful return to work were both having to do with the effects of the brain injury. They were having to do with the family status and how they're functioning, or their availability or lack thereof. And it was clear that there were social barriers. So for the individual and family level kind of barriers. What we wanted to do is to, first of all, as I said, provide brain injury education. Secondly, we wanted to, after we do an evaluation, promote access to and coordination of services as I described. And then third, ongoing assessment of progress towards goals, and then monthly team conferences. And our team includes a resource facilitator. It includes what's called a local support network leader, and I'll talk about that in a minute. There's a clinical manager, and in this case, that's my wife, Laura Trexler, who's an OT specializing in brain injury for about 30 years. And then myself as a neuropsychologist. So that's the team of people involved in this service delivery process. So this kind of gives you a schematic of the process. So we do an initial evaluation that we call a neurovocational evaluation. It has elements of a neuropsychological examination in that there are some measures of cognitive functioning and personality. But the scope of the evaluation is broader than a neuropsychological examination. It doesn't go as deep because we're not trying to diagnose brain injury. That diagnosis has already been made. And we generally have an idea of what some of the main cognitive sequelae are of that brain injury. We need to drill down on some of the larger cognitive domains in the examination, but we also need to look at things like substance abuse. We need to look at family support. We need to look at criminality, past criminality. We need to look at anger and aggression kinds of issues. We need to think about what resources are available in the environment in which they live, including transportation or providers in that area. And so the scope is much broader than a classic neuropsychological examination. And as you well know, neuropsychological examination is useful for having some idea about return to work, but it's not particularly predictive of return to work or success of return to work. So a broader data set is required, and that's what we assembled in this neurovocational evaluation. So that's what gets us started. And then as we embark on the resource facilitation process, hopefully we get these people fairly acutely, and we have the opportunity to integrate what's happening in outpatient rehabilitation in the clinical world with the kind of vocational and community-based services and supports that they're entering into as they transition from healthcare systems to other systems of care. You all understand fully that one of the reasons resource facilitation is so important is because these two worlds are so siloed and disconnected between health and other kinds of community-based supports and services. So we try to get these people engaged as quickly as possible so that we can begin the resource facilitation process and maybe even try to prevent some of the comorbidities and co-occurring conditions that are associated with trauma before they get depressed or before they get into major substance abuse through trying to carefully navigate them towards success. But in any case, the point is to start in a way so that we can promote integration and transition between healthcare and community-based support services, and then continue to follow up on a scheduled basis where we're coordinating and integrating those clinical worlds and those community-based worlds to maximize outcome and recovery. But I said that there was a service level of intervention that's provided essentially by the resource facilitator and as guided by the team. But the other level of intervention that I mentioned was provided by a person we call a local support network leader. And these people don't actually carry clients as cases, Rather, they are in the community. There's 3 of them in Indiana, one in northern Indiana, one in southern, and one in central Indiana. And their job is to address the system barriers, the environmental and social barriers that affect success or lack thereof. So it's the job of the LSN leader to provide education to the community. So they're doing in-services for mental health providers, to criminal justice organizations and entities, to maybe primary care physicians, or to vocational rehabilitation counselors, whoever. So that they have some basic understanding of brain injury, so that when a client does hit their system, then they have some awareness and knowledge about what that's about. Their second job is to identify resources in their area that either have some capacity in brain injury or open to developing some capacity in brain injury. And that can cut across all of the potential organizations and entities, health and mental health care, state agencies, transportation, employment services, and so forth. And then their third job is to promote coordination and partnerships, so that there is some continuum, so the providers begin to learn how to work together, and how to form, in essence, sort of micro continua in that community, so that there's collaboration and sharing of brain injury specific resources and supports. So as I said, these services and supports we're looking at may be quite instrumental. Literally, we've taken a number of folks that are homeless, or that need food, or we may be promoting access to cognitive rehabilitation, or to a physical medicine and rehabilitation physician, which are highly specific professional brain injury services. So it just depends on what that patient needs and what the right timing for that service is. So we did our first, I started off by saying we started off with a randomized controlled trial. And it was a small one. We recruited 22 people from the Rehabilitation Hospital of Indiana, which is an inpatient and outpatient brain injury system connected with Indiana University and hospitals, and also St. Vincent's hospitals in Indianapolis. And so we recruited 22 people from the inpatient hospital setting. So these are people, like a month post-injury or something like that. And at the time, we only had money for 6 months of resource facilitation. And I already mentioned the team there. And also we had on the team a representative from Vocational Rehabilitation, who was their TBI specialist for that office, that we had trained through one of our grants. So we had TBI specialists in the VR offices. These 22 people were not just traumatic brain injury, but also included intracranial hemorrhage, stroke, and other kinds of acquired neurologic disorders. As you can see here, the control group, there were 4 people with traumatic brain injury, 3 with intracranial hemorrhage, 3 with stroke, 1 with other. And then in the treatment group, you can see the distribution there. And there was no difference between the 2 groups in terms of diagnoses. We also found that there was no difference between the groups for age, sex, education, or severity of cognitive impairment. So the 2 groups started out quite equivalent, actually. What we found after 6 months was that the resource facilitation group went back to work at about 64% of them, and the control group returned at 36%, which was significant at the 0.0001 level, and which was astounding. I have to honestly say to you that I didn't think after 6 months of resource facilitation we would find anything, but it quite shows you what I know about it. So the other thing we found was that there was an interaction with time, and that means that people who got resource facilitation got better faster. So this is data on a measure called the Mayo Portland Adaptability Inventory, which is essentially a measure of participation. That is, how independent are they at the home and in the community. And since it's a measure of level of disability, a high score is bad and a low score is good. So what you see here in the dotted line is this is where the control group started off when they were just coming out of the hospital. And they clearly made progress over time and became less disabled at 6 months. But if you look at the resource facilitation group, actually they started off a little bit more disabled than the control group, and ended up considerably less disabled compared to the control group, and statistically significantly so at 0.007. So meaning that both groups got better, but resource facilitation participants got significantly less disabled relative to the controls. So based on that, we went back to vocational rehabilitation. Again, this issue of using outcome data to influence policy, I think is one of the messages I want to send here. We went back to vocational rehabilitation with these data and said, this is interesting. These data seem potentially promising. We'd like to test this in the field now. So, a randomized controlled trial is not necessarily the real world. It's an experimental manipulation of conditions to test the efficacy of an intervention. But that's not necessarily the same as taking people that are in vocational rehabilitation and examining what would be referred to as the effectiveness of a service. Efficacy and effectiveness are not necessarily the same things. So we wanted to get a group of people from VR that were already involved in VR services to test then the effectiveness of resource facilitation. So we had, they referred to us 161 people for resource facilitation. For a variety of reasons, 25 of them never started. 10 of them did not finish. They either died or moved or changed. They decided they didn't want to return to work. And when we did these analyses, we had 57 cases that were still active and still involved in resource facilitation. And so 12 had already finished services when we did these data. So we had a total of 69 cases we were able to analyze. They're in marked contrast to the randomized controlled trial. These guys, their average time since injury was 9.28 years, which shows you how disconnected healthcare is from vocational rehabilitation. And their average age was 38 years, 78% male, 54% had greater than a high school level of education, and they were predominantly white. And what we found in that cohort was 67% of them returned to work or school with an average of about 11 months of resource facilitation. 33% were not successful. So that was interesting, and that was pretty compelling. So we went from 64% in the randomized control trial for acute or relatively acute patients to 67% for people 10 years post-injury. And Ball State University economists thought that this was probably important. So they did a study of the economic impact of moving the return to work rate to 67 or 64% is the benchmark they used. So what they did is, and I don't understand healthcare economics in the slightest, but their findings were that in an annual aggregate lifetime economic impact, that is the cumulative benefit of those individuals who would return to work, what is their lifetime economic impact on an annual basis. And what they found was that each year then Indiana picks up $250 million, $249 million in wages and benefits. New revenue from taxes almost is $31 million. Savings to Social Security and private disability is $80 million. Impact on SNAP is 6.6, with a total economic impact of about $367 million a year. So we started to get now then the attention of the state as it relates to the power of the model and its and the impact on return to work. I also should have mentioned that about 8% of the people in these studies were returned to school, not work. They were so when we say successful outcome, we mean either return to competitive employment or return to post high school education. These data were exciting, and we were excited about all of it and gaining momentum. But we also thought maybe we needed to do a replication study, another randomized control trial, which was funded as another randomized control trial through our state research fund. And in this case, we recruited 44 people, again from RHI, from the hospital, or immediately thereafter. Randomized them, so 22 got treatment, 22 got control or regular follow-up. And in this case, they got 15 months of resource facilitation because we had the funding to be able to do so. Again, these patients were quite recent after injury, is 64 days post-injury. Average age is 37, again, 62% male. A little more educated than the previous RCT, 13.6 years, and again, predominantly white. So the randomization worked really well again. The two groups were equivalent for age, sex, education, time since injury, and diagnosis. Interestingly, there was a significant group difference on the verbal IQ of the WAIS-3. The treatment group had a slightly better verbal IQ. I don't know what that means. I don't know why it happened. I don't think it has any impact. In fact, we controlled for that when we looked at our outcome measures, and it didn't, but we found it as a group difference when we started. These are the diagnoses again. So we had traumatic brain injury as the majority, intracranial hemorrhage, stroke, and other. We used, in this case, a vocational independence scale that was originally developed by Dr. Jim Malik at Mayo. We modified it slightly to include education. And so a 5 is good and a 1 is not, and 5 is competitive. 4, transitional work or school enrollment with temporary supports. 3 is supported employment, 2 is sheltered, and 1 is unemployed. What we found was that the group that got resource facilitations had significantly better outcomes, again, in terms of their vocational or educational outcomes. And they not only was their ultimate outcome significantly better, but they also got there faster than the control group. So that was good. We found that 87.5% in the treatment group with a goal of return to work as opposed to education were successful. And in this case, 50% of the participants in the control group with a return to work goal were successful. So that's good because as we noted from the previous research that it was about 40%. So 10% of this cohort, 10% more return to work in this case. When we further analyze these data, if we ask this, whether you get into resource facilitation or if you're into the control group, what we found was that outcome, the group assignment predicted outcome. That is, so 67% of the cases were correctly classified just based on which group they got assigned to in terms of their outcome. So treatment condition was a really powerful variable. And if you got into the resource facilitation group, you were 7 times more likely to be either in school or working than if you got assigned to the control group. Another kind of analysis called a relative risk analysis showed that the risk of having no productive community-based work, either education or work, was 75% higher in the control group. And so those were really powerful findings again. 78% of the positions were full-time. For the treatment group, 90% of the positions were full-time in the control group, so they did better in that respect. This was also an interesting finding. For those in the control group, 67% of them returned to their previous type of occupation, not necessarily the same employer, as compared to 80% of the resource facilitation group. So based on the 2 randomized control trials and the larger prospective clinical cohort study, as well as the economic impact study, the Indiana Vocational Rehabilitation Services decided to make it a policy now that people can receive resource facilitation that they will pay for people with acquired brain injury and who have a return to work or return to school goal. So that was effective in 2014 after we had done these studies. So what happened in Indiana was that we started in 2009, as I mentioned, with our initial work on this project. And we did this initial small randomized control trial, and we recruited people from central Indiana. Indianapolis is in Marion County, and really these donut counties are suburbs of the larger Indianapolis area. And we were also doing a little bit of work up in Allen County, which is where Fort Wayne, Indiana is. But the vast majority of our people were recruited, the small sample in this first RCT, from central Indiana. And then we did the larger clinical trial that I mentioned that now surrounded, that expanded the central Indiana area and also expanded the northeast sector of Indiana. So then based on the policy change, now we had an interesting situation, because Indiana VR did not want to be just providing a service in part of the state. So they said to us, well, how are we going to get resource facilitation throughout Indiana? So I drove around Indiana for a couple of months, talking to a variety of people, hospitals and clinics, employment services providers, and the like, trying to get them to provide resource facilitation services. We said that we would train them how to do it, and that the state would pay them to do it. And I couldn't get anyone who wanted to do it. I think they thought I was either had lost my mind, or which may well have been true. But I could not find anyone who wanted to provide these services. So I went to my CEO at the Rehabilitation Hospital of Indiana, and I said, well, okay, so what are we going to do? And we made the decision that we would hire people throughout the state and provide this as a service throughout the state. So that's what we decided to do. So then we started filling in these countings in the yellow area, central Indiana sector, and staffing up to serve that, and expanding then northeastern Indiana even further. And then in late 2014, we brought on staff in southwestern Indiana. Louisville, Kentucky is right down here by Jefferson County, and we didn't have any staff there. We had hired some staff down here in Evansville, Indiana. that could cover this area, but we didn't have anyone in this area. And so we then brought on staff in northeastern Indiana. Up here is Chicago. And so this is a very metropolitan area right underneath Lake Michigan here. And then we also staffed southeastern Indiana, just north of Louisville, and then Cincinnati, Ohio is right over here. So by the end of 2014, then we could provide services throughout the state. Then in 2016, what we wanted to do was to expand our capacity to do the initial evaluations at other locations in Indianapolis, because people had to travel to Indianapolis for this evaluation, which was cumbersome and difficult. So in 2016, we established a satellite in Evansville where they could go and have the evaluation. The neuropsychologist part of that was done by telehealth. And then in 2017, we established a satellite in Fort Wayne, Indiana, and then we established a satellite in South Bend area later that year also. So this is most of our current staff. Dr. Ibarra is not there anymore, but Devin Parrott is our clinical research manager and biostatistician. She has been instrumental in helping us do all the statistics and data analysis for all of these studies. This is Laura Trexler, my wife. It was actually whose idea or who brought resource facilitation to Indiana. Peter Bespikos now is actually not in this role anymore. He's the executive director for resource facilitation. And Judy Reuter is the person who held this wild team of people together as best she could. Being not satisfied still yet with the data, we decided to do another large prospective clinical cohort, that is, take a look at the people that we had been referred by Vocational Rehabilitation, and this was done in 2016 because we made a commitment to them to say, we'll continue to track our outcomes to make sure that we have fidelity with our previous data. As you may know, what happens a lot of times, people will do research, and because it's a research project, they get one kind of outcome, but then when they roll that out into clinical practice, a lot of times there's drift or regression in outcomes for a variety of reasons. And so we said, well, we're going to continue to track our outcomes to make sure that there's fidelity between our research and practice, and also as a matter of continuous program improvement. So we took a look at 141 people who had come through the service. Again, their age was about 39, which was consistent. They started off as moderately disabled. They were a T-score of 43 on the Mayo Portland, and that's associated with a moderate level of disability. They were 10 years post-injury, 63% male, and 13 years of education. And what we found for this cohort was that there was 70% successful placement in competitive employment. The mean hours per week was 25 for that group. We also took a look at activities of daily living for this group, because we were using the Mayo Portland, but we wanted to drill down a bit more specifically into some of these specific activities of daily living. So self-care, household care, employment and recreation, shopping, money management, travel, communication, and then an overall score. And what we found for this group of people that was 10 years post-injury is that there was a highly significant reduction in level of disability on this measure at 0.000, which was really exciting to see for us. We also used a scale called the Survey of Unmet Needs and Service Use. This is a really cool scale for people working in this area and in post-acute community-based services to use. It is a scale that was developed specifically for people with TBI and specific to measuring needs and services. So It's a test that asks the person. Let's take, for example, there on the bottom of the slide. On one hand, on the left-hand side, you said receive help now, and on the right hand, it says need or want that help. So take traveling in my community. On the left-hand side, do they receive that kind of assistance now? Yes, no. On the right hand, do they feel like they need it or want that kind of help? And it covers both instrumental kinds of needs, traveling in my community, finding housing that's affordable, but then also things like controlling alcohol or drug use, improving my memory, controlling my temper, things that are maybe much more specific to those with traumatic brain injury. What we found was that after resource facilitation, there was a significant reduction in the number of services used from baseline to discharge. So that was significant at 0.005. So the blue is the number of services that they were receiving when we got started, which was about 7. And by the time we were done, it was 5. And the services desired declined from about 8.5 or 9, as I recall, down to 3. So this was significant at 0.000. And it was both for instrumental as well as brain injury specific kinds of needs and services. And so that's fantastic. But again, to go back, this is an oversimplification, but if you carefully evaluate someone from a broad spectrum, with a wide net, and you find out what are the barriers, what are the problems, what are the issues that this individual has, and then you find a way to navigate them to services and supports to address those needs, it's not startling that their services decline and their perceived needs decline also. If you get them what they need, they feel better and they function better. Of course, it's much more complicated in the process of doing that, but that's the story to the slide, really. We also used the Mayo Portland for this group and administered it before and after resource facilitation. The gray bars here are their baseline admission ratings, and the red ones are their discharge. Again, because it's a measure of disability, high scores are bad and low scores are good. Here are the levels of disability. Overall, for the total Mayo Portland, you can see that, as I mentioned, they started off really kind of in the moderate range, a T-score of 50, a level of disability, and at discharge, they fell into a mild level of disability. But it was true for all of the metrics or the indices within the Mayo Portland. The abilities subtest, this is also a great measure for people working in community-based services. The abilities subtest includes things like mobility or memory, and again, this scale was developed specifically for people with traumatic brain injury. And we saw a very significant reduction level of disability for the abilities index. The adjustment index is things like you might suspect: depression, social interaction, family stability, and the like. And we saw a really significant reduction there that was at 0.001. Participation, I mentioned before, it's how independent are you at home and in the community. So managing your money as an example, or transportation. And again, we found a 0.001 change from beginning to end of resource facilitation. So the total change was in fact at 0.000 for a group of people that's 9 years post-injury. In our last HRSA grant, the one before our present grant, we were working with the Department of Corrections, and so it's well known that people with traumatic brain injury are much more likely to be engaged with the criminal justice system. In fact, the data, when you look at the rates of engagement, what you find is approximately 25% of people within the first 2 years after having TBI will be engaged with the criminal justice system. And by 5 years, actually it's 38% to 40% of people will have their first engagement with the criminal justice system. So traumatic brain injury is a risk factor for incarceration. And in this study, we also wanted to look at recidivism in a group of ex-offenders that were coming out of prison, and were they more likely to then end up back in prison? And what you see in the upper left hand then are the data for that group. What we found at 6 months was that 22% of people with traumatic brain injury recidivated versus 18% that did not have traumatic brain injury. And at 12 months, we found 34% had recidivated versus 32, interestingly. And our finding is actually a little low compared to now some other studies that have been done on the effects of TBI and recidivism, but that's what we found in this particular study. And I forgot to include a slide on how many subjects, but it was about 1,300 people, I think, in this phase of the study. We also provided resource facilitation to a small cohort. This sample size was less than 40, as I recall. But what we did find was a really significant impact, statistically significant impact of resource facilitation on recidivism. At 6 months, those people that got resource facilitation, only 10% of them recidivated, as opposed to 22% at 6 months that did not get resource facilitation. And at 12 months, we found a 9% or 11% reduction in recidivism compared to the control group, 23% recidivated at 12 months versus 34% that got regular follow-up. We also had a couple different levels of resource facilitation that were being provided in that study. And it had to do with a variety of reasons that I won't go into, but one group got what we described as kind of resource facilitation light, as opposed to the full resource facilitation program. And there's this really nice dose-response relationship, and you see that at 12 months post-release here, the group that got full resource facilitation had a recidivism rate of 12%. The RF light group had 26% recidivism, and the group that had no resource facilitation had 34%. So there is a dose-response relationship for the intensity and the complexity of the service provided. So in aggregate, over the last 10 years, with this model of resource facilitation, what we found is significant improvement in return to work and school, both in pretty acute populations as well as quite chronic populations. Others found that to be having a significant economic impact. We've also found significant reduction in services used and desired, significant reduction in level of disability, and now a significant reduction in recidivism. Our current ACL grant is now taking a look at the ability of resource facilitation to not only reduce disability again, but to look at the issue of incarceration as well as substance abuse. And let me give you the background on that. So I already mentioned our work in the Department of Corrections. But during that grant, I began to feel that I was missing the mark, that it was great that resource facilitation was preventing recidivism and helping in that respect. But I talked to so many people that were coming out of prison during that grant that really had no idea and no understanding of their brain injury and no understanding of the role of their brain injury and why they got incarcerated and why their families fell apart and why their lives, why they lost their jobs and why they started substance abuse. And it became, I felt guilty in a way because I thought, why aren't we doing something to try and prevent this from happening in the first place? And so in our current ACL grant, we're recruiting people straight out of the trauma center and starting them in resource facilitation then. And so two of our outcome measures, or one of our outcome measures is incarceration. So we will be looking at the data next spring to say, okay, of the treatment groups that got resource facilitation versus controls, how many in each group ended up being incarcerated? I'm a little concerned because it's only 1 year of resource facilitation after the trauma center. And I think that if we were doing 4 years of resource facilitation, we might have a much better chance of showing an effect, but we'll see. I don't know. Maybe we will. I didn't think we'd show a finding in the first study anyway. But the other thing that has happened in the interim is that a group of researchers and I did a group of researchers did a study looking at opioid overdose. There was a study done looking at accidental poisoning or death following traumatic brain injury amongst the traumatic brain injury MOP systems sites. And what they found was that people with traumatic brain injury were 11 times more likely to die of an opioid overdose, which also just startled me to death. But then after looking into it and doing some research, then the reasons, of course, became obvious. Number one, we know that a number of our folks have substance abuse issues prior to a traumatic brain injury, and substance abuse is clearly a risk factor for traumatic brain injury. Secondly, 54% of people with a traumatic brain injury will have chronic pain. So either headaches or associated with orthopedic injuries that were suffered at the same time they got a brain injury. So now we have a person with acute pain. Then we have the situation of someone prescribing an opioid, not knowing that they're prescribing it to someone with a substance abuse history, and also not understanding the neuropsychological effects of the injury on taking an opioid that may include reduced inhibition or reduced judgment or memory impairment and forgetting that you've already taken your medicine, and not considering how those neuropsychological factors may increase their risk even more. So now we have pre-injury substance abuse, we have the effects of the head injury, we have chronic pain, and then we have providers after the traumatic brain injury prescribing opioids. They go back to their orthopedic doc, and the orthopedic doc isn't going to think about the traumatic brain injury or their primary care physician, even if they know about it. And so that prescription continues, and now we have a legacy. And so for these reasons, people are 11 times more likely to overdose. So in this current trial, we're also looking at, can we prevent opioid misuse and overdose? And in some other talk, maybe someday I'll share with you the clinical surveillance system we've developed to track on a monthly basis and more frequently as needed these kinds of variables so that we can use data-informed resource facilitation to manage around these issues. So that's our current activity in resource facilitation, our next steps. We're just starting now to think about the next ACL grant and how we'll do that. These are some of the research grants that have supported this program of research. These are the core references to the resource facilitation outcomes. And thank you very much for your time. I think we've got some time for questions, and I'll flip back over to my good buddy, Jeffrey.
Hey,
thank you.
Thank you. Can you hear me, Lance?
Indeed.
All right. I heard the hounds being called out there for a few minutes, but that was an interesting diversion. I don't know. That must be your new ringtone. I do want
Yeah, it
to,
is actually. Yeah, I forgot to turn it off.
No, it's okay. It's unique, and it is quite Trexlerish. The time is the top of the hour, but I would invite anybody who has a question to type it into the chat box now, and or to email Margaret at the same address that you got the login information for here. And we will push these questions to Dr. Trexler. We'll try to answer them if we know the answers, Lance, but if we don't, we might throw them to you. We'll wait till we get a batch and we may give you a call and try to do some quick note taking so you don't have to spend too much time typing answers. But very much appreciate your leadership in this area of resource facilitation. I will share that I was on a call with the ACL leadership last week, and as well as Neidler. A couple of things are worth mentioning. One is that Indiana University was recently announced, I don't think it's been out in press release yet, to have received a Neidler grant, where Lance and his team is, to look at brain injury as a chronic disease over the next 5 years. That dovetails with what I've heard Dr. Trexler talk about as he gives presentations around the country, that resource facilitation may well be a very significant treatment in brain injury as a chronic illness, a community-based treatment. And so, Lance, you're really pushing the boundaries for us all to try to figure out how to help people live well with brain injury, which is part of what the mission of many of us is, USBIA, BIAA, NASHA, and others. So I'm looking to see, there was a question that we can push through, Lance. There's one here asking whether the study was solely in Indiana.
Yes, yes, it was. We do have a study being reviewed now. It looks like it will probably be funded to happen in conjunction with Southern Florida University, where we'll be looking at adolescents with brain injury and whether we can improve recidivism in adolescents through resource facilitation. That'll be done in conjunction with Dr. Drew Negley and also with Dr. Christina Aspiaga, or Dillahunt Aspiaga in Florida. So we're really excited about that. That's a proposal we've made to the Department of Justice, and things look pretty positive for getting that funded. So that'll be our first study outside of Indiana. Sure. But to date, no.
So there's another question here that maybe we can both field. It's from Kristen Alexander in Arkansas, where they have no trust fund and no waiver, and she's the resource facilitator for the state. Thank you for joining us, Kristen. She says her biggest problem is a lack of resources to refer to, a lack of resources to refer to. How do you find and navigate that in Indiana, Lance?
Yeah, thank you, Kristen, for the question and your interest. So I think, I think the issue is that there's lots of potential providers out there. And this is what ACL grants are particularly good at helping do, is build state capacity. So you may want to think about that, Kristen. There's, there'll be a request for applications probably in January. Building state capacity to treat people with traumatic brain injury is a major agenda. And so the states have done that in a variety of ways. Jeffrey probably knows more about that than I do. And you also may want to talk to the National Association of State Head Injury Administrators, NASHA, National Association of State Head Injury Administrators, and both Jeff and I can get you an email to someone there because they have a great deal of experience on how to address your question also. I think my experience is most of the time is that people are generally open, but they need a curriculum. and they need a method to access that. And one thing you may want to also look at, Kristen, is Dr. John Corrigan's resources on the Ohio Valley Center for Brain Injury. He has got a beautiful web page with all kinds of resources built into it that serve your question on how to screen for brain injury, how to make accommodations for brain injury. And then the other thing is the University of Oregon's, what's their name,
CBIRT,
Jeffrey?
CBIRT.
Center for Brain Injury and something in Oregon.
Research and Training. Yep.
Have developed this incredibly cool online, and it's free too, isn't it, Jeffrey?
It is.
Yeah, it is free curriculum on entry-level brain injury training.
Right.
And so getting that out to people that will listen, Kristen, are all things that I would consider you think about.
Kristen,
and
let me give you,
email me.
Let me give you one case study from our neck of the woods in Iowa. A number of years ago, there was a bit of an expansion of funding for the mental health and disability system. And brain injury advocates got a single line added to the administrative rules that in addition to screening for substance abuse and for mental health, there had to be a screening for brain injury. Well, after that made it through the 2-year process until suddenly the providers were like, whoa, screening for brain injury. The state, with support from the federal TBI program grants that Dr. Trexler was talking about, adapted Dr. Corrigan and the Ohio Valley Center's screening tool to Iowa's definition of brain injury. And we were ready to roll that out for screening. Now, it begged the next question. Okay, so somebody screens positive, now what? And then the now what was training curriculum that we had already thought through and are now providing in a number of modalities. But this really is as we all know, it's a marathon as opposed to a sprint. And we are incrementally increasing awareness and increasing capacity to serve people with brain injury in systems of care that are, we'll just say at this point, less worse than they used to be. I think we have a long way to go before they're optimal, but they're clearly less worse.
Hey,
all right.
Jeff,
Yes, go ahead.
One follow-up, not to derail too much, but this is Kristen talking.
Oh, yes, thank you.
So what training curriculum, did y'all come up with your own, or did you use one from somewhere, or was it that CBIRT?
Well, CBIRT is second to none. I would look at that one right now. We had one, we've had one at the Brain Injury Alliance that we've partnered with our state agencies, and we'll customize that to some degree for the different providers. We have a specific focus on mental health and substance abuse this year and have over the last few years. So the resources are there. The dilemma we have is the bandwidth and the time to be able to do the training that's out there. So basically trying to form groups of the professionals who can give these trainings, because many people wanted them face-to-face until March, and now we're doing all Zoom webinars. But it does take a long time. So if you were to look at, and choose a training that you felt was worthwhile, and then either deliver it via Zoom to your state folks and just kind of keep plodding along in that way, it starts to increase, it does increase capacity in bits and pieces. Then the dilemma is making sure that the funding follows for the brain injury specific services and supports. But most providers, at least here in the Midwest, would prefer to serve people most appropriately. They just don't know how yet.
Right. Yeah, we have a lot of those. And would you be willing to chat more directly about?
Absolutely. You can reach me via Margaret. You can just, she'll connect you with me. So I do have to be blunt though, just because we want to make sure we wrap up here as close to the top of the hour. I think we could go through a number of other questions, but again, this has been the United States Brain Injury Alliance sponsoring a really well-received and excellent presentation on resource facilitation. outcomes and advocacy. Lance, thank you so much again for taking the time to move the ball forward, both in your professional life, but then also to share it across the country as often as you do.
Yeah, thank you. And I've got my contact information up here also now, Jeffrey. I hope you guys can see it. There's my email address if I can be of assistance to you guys. So thank you very much for the invitation, and all the best to all of you. Thanks.
All right. Thank you all. Bye-bye.
Thank you very much. Take care.